Welcome to the eClinicalWorks podcast. This is part 2 of a conversation with Rohan D'Souza about MACRA, MIPS, and what it means for you, our viewers, and our clients. Before we get into our APM discussion, just to round out our conversation about the MIPS area and the different measures and activities that you'll be asked to report on. I think you mentioned that CMS did a lot of listening to practices. I think it's also evident in the fact that they've expanded or made available a lot of choices there in the quality component, in the improvement activities component, so that practices can really pick and choose which activities either line up best with what they're doing now, line up best with where they want to go and what's important to them or important to their patients, and figure that out. Let's just use the example of a dermatology practice, because I had a dermatology practice speak with me at our national conference about their concerns regarding this. And under PQRS, which is now quality in the MACRA program or MIPS component, they said that under quality, under PQRS, they only had 4 measures to choose from, and so that was very difficult. And some dermatology practices might not even do all 4 of those. If we look at the quality measures that are available under MIPS, there's actually 11 that are specific to dermatology, so it's more expansive there. And then the improvement activities category, there's 93 options to choose from, of which you only need to pick, maybe 1 to 4, essentially, and some of those are generic and applied to any specialist, no matter who you are. So there's a lot of choice, a lot of flexibility there. It's not like we were seeing with meaningful use, where practices were complaining that they were being put into a box that didn't mean anything to them. So I think there's a lot of improvement.
Yeah,
there.
it's a really good thing that CMS did, Adam, and I think this goes back to our point that we made, or the question that you asked me: should practices be worried? And I think that this is what's added fuel to the fire with a lot of media agencies and a lot of professional organizations that's saying, because there are all of these options, you need to be worried. When in reality, you're avoiding that square peg in a round hole type situation. Now your dermatology practice that only had 4 options to pick from now has 11, right? We talk about urgent care, you talk about nephrologists, endocrinologists, they're all getting more options that means something to them, and not, I have to do this or believe in this model of checkbox medicine just so I can check off the box and saying, okay, I've attested for meaningful use or PQRS.
And additionally, CMS has also said that they are going to be reevaluating which measures are available every year. So if you find that something doesn't work the way that CMS thinks it works, or if you think that there's something additional that you feel would be more applicable and beneficial to your specialty, subspecialty, to medicine in general, you can put that forward, and CMS, as we've seen, will likely listen to that.
Yeah.
So let's get into the advanced APM discussion now. If providers find themselves part of one of these organizations, they can avoid reporting under MIPS, because as we know, they'll probably be doing much of those activities already. Let's talk about what defines an APM, and then what makes an advanced APM different, and we can start to discuss whether providers might be part of those and what they'll see as a result.
Yeah, great question. It's gotten a lot of discussions across the board, especially since ACOs have become more mainstream starting in 2012. APMs essentially are alternative payment models. Really defines the very word of shared savings and a reimbursement based on cost reduction / improvement in quality, right? So if you look at the IHI triple aim, all of the APMs focus around achieving the triple aim, right? How can I deliver a better value of care at a lower or a controlled cost level by not compromising on patient satisfaction? And that's what APMs really focus on. There's some requirements there. You have to use a certified electronic medical record. You must have care coordination in place, et cetera, et cetera. What makes an advanced APM is when you start to take on this model of dual-sided risk. Essentially, you are now on the hook by you as a provider or an organization that is taking part in this advanced alternative payment model. You're on the hook with the sponsor. So the sponsor might be Medicare through the ACO model, or it could be a large health plan like United or Blue Cross or Humana or Aetna. Essentially, if you increase your costs, you are now not only having to pay a fine, but you're sort of put in that category as an ACO that increased costs and paid a fine over to CMS, right? So you're taking dual side risk. And the reason why CMS is saying that we're going to give you that blanket 5% increase with your payout structure if you are in an advanced alternative payment model side starting 2019 is, on one side it might look great, Adam. It might say, okay, why do I even have to bother now with MIPS, with the worry that I might get an increase in 2%, 3%, or 4%, versus if I just go to the advanced alternative payment model side, I'm going to get an increase in 5%. But the reality is you're on the hook now. You're on the hook for paying back fines if you increase your costs. So while you might be getting an increase on one side, you might be having to pay fines on the other side if you're not doing the things around the triple aim, right? If you don't have care coordination in place, if you don't have constant communication back and forth between your patients, working with your acute care locations, your hospitals, your reduction in ER visits, you might be increasing costs that you might not even know and having to pay a fine towards the end of the year. So the advanced alternative payment models, like we talked about, are the MSSP Track 2, Track 3, and the next generation ACO. Most ACOs today are in Track 1. About 90% of MSSPs, there's around 400 of these, are today on the single side risk model, which is Track 1. And what CMS has said is that Track 1 doesn't qualify as an advanced alternative payment model. It just qualifies as an alternative payment model. So while you might get some discounts on the MIPS side where quality might not be 60%, it might be 50%, things like that, you're not going to get that additional 5% blanket that you might get under the advanced alternative payment model side. So CMS is introducing a new program starting in 2018 with rules to come out in 2017 called the MSSP Track 1 Plus. It's basically a program that will allow folks that are in the Track 1 MSSP today to switch over to Track 1 Plus, or allow folks to newly enter into the Track 1 Plus MSSP, where there will be a little downside risk, not as high as it is in Track 2, certainly not as high in Track 3, and definitely not as high in the next generation ACO, but it will allow them to now take on that dual side risk model and get that 5% payout. So, I would tell practices to pay close attention to that starting in 2017. And then, of course, if you're one of those fortunate practices that got selected in one of the 14 regions of CPC Plus, whether you're Track 1 or you're Track 2, not only are you getting an investment model to stand up care coordination, but you're also avoiding MIPS, and you're applying now under the advanced alternative payment model side.
So, you mentioned, yes, there is some risk involved, and certainly we've seen that some ACOs have ended up owing CMS some money. But I think it's clear that CMS is betting that this is the way to go by consolidating, or maybe not even consolidating, but by better coordinating with other practices, whether it be by joining a large organization or forming some sort of a loose independent physicians association type of thing. I think they're betting that additional communication, additional coordination, additional sharing of information is going to lead to reductions in cost, right? Because that's the power of a network, right?
Yep.
That your efforts are amplified by the other people in the network. Now, and to that end, of course, CMS is also introducing or considering introducing the concept of forming a virtual group in 2018. And for groups that are not part of an APM already, but maybe don't feel like they can go it alone, or don't feel like their reporting is going to meet all the quality metrics, they can join a virtual group or form a virtual group where they can report with other practices, aggregate their MIPS scores, and be reimbursed basically on the score for the entire group. So I think that's kind of evidence that CMS is hoping that practices will move in this direction, even if they still try to remain independent.
Agreed, yeah.
So I guess the final question that we really want to talk about, or one of the final two questions that we want to talk about, is what is eClinicalWorks doing now, or what are we planning to do in the near future to support this and be ready for this? What can we offer to practices?
Yeah, so Adam, let's categorize this into 3 Ps, right? So we've got the people, In addition to you and me understanding these rules, there's hundreds of folks here in the background here, all over this building, all over the country, that have really spent a lot of time understanding the subtle nuances within MACRA, whether it's the MIPS piece, whether it's the APM piece. So, rest assured that practices can depend on eClinicalWorks' staff to help them throughout this process and remove some of that anxiety. Let's talk about product now, right? So at the end of the day, we are a software provider for mostly all of our listeners and for a large percentage of independent docs across the country that are interested in what is eClinicalWorks going to do for me to make sure that the software is certified, there's pieces in place. So on the product side, if you were at our national conference, you heard that we have introduced a MIPS dashboard. The dashboard will be available beginning right away in January 1, starting next year, where practices will be able to see all of their components in one single view, whether it's the ACI component, whether it's the quality component, whether it's the improvement activities component, integrated directly into their EMR to allow them to see how their providers are performing, how their groups of providers are performing, or how their entire health system is doing. We've always supported the submission of these quality measures as a data submission vendor. We've been doing this for many years now with PQRS, and we'll continue to do that. We'll continue to help practices support or submit their measures over to CMS, whether it's QRDA, XML, whatever format CMS comes up in. Rest assured, eClinicalWorks will be on top of that. And then there's more cutting edge technology we're putting in place, right? If you're in the advanced alternative payment model side, you need to understand your HCC coding. How is that going to impact the risk scoring of my patients? What are the gaps in care? How do I make sure I get that high benchmark or that sustained benchmark so I can work with that truly capitated model of working within that budgeted amount set aside for this patient? If I don't code you at the highest level of specificity, CMS is just going to think you're the average Medicare patient, when in reality, you might be a patient with multiple comorbidities and interaction factors between these comorbidities will change reimbursement. So we're helping practices with people that will help practices understand what is HCC coding, how does that impact their workflow, but then also from a product perspective, how do we look at risk scores at the point of care? How do we get notified as opportunities at the point of care? Quality measures, things like looking at your HEDIS scores, looking at your other metrics are all things that we're putting in place from a product side. And of course, we have a fantastic care management and care coordination application embedded right within the EMR. Care managers, care coordinators, your chronic care nurses can all look at this from the standpoint of what's happening with their patient and track that throughout the continuum of care and not just look at a single encounter. And the last P, Adam, is process. How do we take all of these and put it together into a protocol and a process? In fact, right on this floor, we've got our business analyst team, I believe, which you're a part of, that focuses on things like optimization services, really comes in and help practices understand, okay, are you patient-centered medical home? Maybe you're not patient-centered medical home. Can I help you become patient-centered medical home so you get the 100% on the improvement activities and you bypass that track, right? That's really where the rubber hits the road. It's not just product existing in one place and people existing in the other place. It's how can we marry these two together along with our listeners and our providers into one unified process. And that's what ECW is doing.
And then the last question, now we know that what eClinicalWorks is doing, what are our viewers supposed to do? What are the providers and the offices and organizations supposed to do first when we're headed into MACRA?
Well, the first thing I will tell our listeners is don't be scared. There's a lot of nervousness out there. We're hearing some stories of how practices are saying, oh my God, am I going to be able to continue to maintain my small independent provider office? Whether you're in a densely populated metropolitan area or in a small town, rural America, don't be afraid. MACRA is nothing but a modification. And it's very easy to make it sound like it's overly complicated. That's the first thing I will tell our listeners, is not to be afraid. Second is just get educated. Listen to things like this podcast, listen to eClinicalWorks' webinars, maybe talk to your local community resources. health systems that might be in place, your professional organizations. Most providers today are part of either one or multiple professional organizations that are conducting these similar webinars and podcasts on MACRA. And the third thing I'll say is do something. Do at least the bare minimum to avoid that negative payment. Like we talked about under option 1 with reporting with MIPS, do even one quality measure and you avoid the negative payment adjustment. Look at forming an ACO. Look at getting people together to take on some amount of risk, because you can do that in today's modern medicine of having technology, of having people, of having a consumer that understands this whole idea of risk, working with hospital systems, skilled nursing home, home health, form an accountable care organization. CMS is making this a lot easier to do today than it was in the past. And just, you guys got this. This is not overly challenging. And we're going to help practices to really navigate this and be successful at it. So that's my message.
Well, Rohan, hopefully our viewers feel a bit more confident, a bit more informed after our discussion here today. Thank you very much for all of that. And you can check out, as Rohan said, check out our webinars on my.eClinicalWorks.com. Speak with your SAM, put in a ticket, whatever you need to do. Get in touch with us if you have questions. We'll be happy to answer those for you. You can also check out our other podcasts on YouTube, iTunes, or my.eClinicalWorks.com. For the eClinicalWorks podcast, I'm Adam Siladi. Thanks for watching.
This broadcast and its contents are the sole property of eClinicalWorks and are protected by federal law and international treaties. You are strictly prohibited from making a copy of, modification of, or form of rebroadcasting or re-encoding this broadcast without prior written permission from eClinicalWorks Public Relations, except as may be permitted by law. This broadcast is provided for informational purposes only. It is intended as a personal, non-commercial use. Product specifications are subject to change without notice. Please contact eClinicalWorks Public Relations with any questions. eClinicalWorks V10 EHR is ONC HIT 2014 edition certified as a complete EHR. eClinicalWorks V10 CC 2014 955447-1.